Good morning, good afternoon, everyone. We'll give it a 1 minute for folks to join. So let's wait for 1 minute. Great, let's get started. Well, hello everyone. My name is Olivier Defau. I'm gonna be your facilitator today for this amazing Updwg webinar. And today we have an exciting topic and a great team joining to talk to us about building the case for drone in health distribution through remote Madagascar communities. And we are joined with staff from the PSI and from AerialMetric, who are the two teams who are testing the drone in Madagascar. Before we start, just couple housekeeping. We will be presenting for about 35 minutes, and then we'll have 25 minutes for Q&A. The webinar is being recorded and will be posted on updwg.org, as well as email to all the registered and Updwg participants. And to contribute, we will do a non-verbally, at least during the presentation part. So through Q&A, the feature is down your screen. You can put your question there, and we will address your question either during the webinar by written or verbally at the end during the Q&A section. At the end, you will be able also to, during the Q&A, to contribute verbally and ask your question verbally by unmuting yourself. But before that, please raise your hands, and so we can manage who will be here. So today, our presenters are Sandra, Daniel, and Pierre-Loup. So Sandra is from PSI Madagascar, and she's the drone project manager. Sandra's background is in science, technology, and project management, with 6 years of experience in monitoring and evaluation in project management. She's intimately engaged in the design, the planning, and the rollout of the project at the field level, and managing donors as well in government relationship at the national and international level. And she's passionate about this topic of drone and drone transport as a way to save people's life in hard-to-reach community. We'll also be joined by Daniel. Daniel, who is the country representative, the PSI Madagascar country representative. And Daniel comes with 20 years of experience working in the public health across Africa and Asia. And he's focused on building the business case for government, donors, and all partners to make investment in and advocate for drone in national health financing forum, and identifying opportunity for scaling the intervention. And last but not least, we will be joined by Pierre-Loup. Pierre-Loup, who is the Chief Executive Officer of AerialMetric, which is the drone technology provider. So Pierre-Loup is a senior leader with close to 25 experience in international experience in the aviation industry, in investment banking and global health, and is particularly result-oriented, analytical, and innovative, which is perfect skills for doing the work that they're doing. So without further ado, I want to pass the floor to the PSI team first. Thank you.
Sound right? I think you're starting.
I will just start with the agenda. So hello everyone. Thank you for joining us today on this webinar. And thank you, Olivier, for this introduction. So our today's agenda will be about PSI Madagascar and joint projects overview. We will present also the randomized control trial, talk also about lessons learned and the technological side with AerialMetric. Next slide, please. Then I think it's you, Daniel. Thank you.
Yeah, I just wanted to take a brief moment to introduce PSI Madagascar. We've been based in Madagascar for around 25 years, so we have a lot of background and experience. You may know PSI to some extent. We work quite widely in public health. In Madagascar at the moment, we have large funding through USAID and through the Global Fund. We are the PR, the principal recipient for funds around HIV, soon to be tuberculosis and malaria. And we have quite a significant footprint working with the Ministry of Health. We're doing a lot of work around capacity building and in really strengthening the health system, which is where the work with the drones comes in, because one of the biggest challenges that we face, that the country has faced, is the last mile delivery system. Move on one more. Okay, so working in drones, there are many projects that have started at small scale. There are not many examples of where drones have been taken to a larger scale. So I think what we're trying to highlight here is that Madagascar is one among maybe 6. I think there's another project in Nigeria that's considered to be also at scale these days, but there are not many that have gone to the kind of scale that we're operating at the moment. Many of which are done with Village Reach, the partner who's helping organize this workshop. But thank you. We'll move on. One more. I just wanted to draw maybe a bit of attention to some of the differences between Madagascar and some of the other countries where drones might be considered more established or well known or whatever. I think Rwanda is considered one of the outstanding sort of examples of a drone project at scale. Rwanda, of course, relative to Madagascar, is like one small province. It has a much higher population density, and access to health facilities is relatively straightforward, and plus they have a reasonably good road network. Malawi also, much smaller than Madagascar, and what was again a difference as you're trying to look at how drones are deployed. With Rwanda, you can, I think the people working there have managed to put 2 or 3 drone sites, and with that they can almost cover the entire country. I think in Malawi, again, maybe 7 or 8 drone sites, and you can reach almost the entire country as well. Part of the challenge we have in Madagascar is many of the sites that are our target areas are perhaps around the edges of the country. So often our drone takeoff point is by the coast, and that reduces the operational what is the the drone can only operate within a sort of a semicircle of the drone takeoff point. So in some ways there are some even bigger challenges that we face compared to, or different challenges that we face compared to some of the other countries. I think the population density is a major question mark when it comes to looking at how you deploy your drone services. Move on one. I think this will ask I'll ask Sandra to jump back in and describe some of the very specific Madagascar challenges that we face.
Yeah, thanks, Daniel. So my intervention will be focused on the project. How did it started? What's the purpose? And main results. So health commodities and vaccines are transported from the central to district level by car. Then health workers have to work several hours or days for the supply chain from the district to the community level. This supply chain remains very difficult during 3 to 12 months per year due to geographical, climatic, and insecurity challenges in Madagascar, which leads to the enclavement of public health facilities. And there is also a frequent stockout of medicines at the public health facility. Next slide, please. Okay, thank you. That's why we use drones to deliver health commodities and vaccines in remote communities. And it began in 2019 in the northwest of Madagascar. It's the takeoff point number 1 on the map. PSI Madagascar initiated with the Ministry of Public Health the pilot phase under the funding of USAID and Global Fund. A midterm evaluation concluded that drones works in Madagascar and the Ministry of Public Health need the drone services. So the scale-up began in 2022 and we have 5 takeoff points implemented now. For each takeoff point, in general, please, can you stay please on the previous slide? Okay, thank you. So for each takeoff point, in general, there are more than 1 district to be served. For example, let's take a look at the takeoff point number 4. There are 3 districts concerned, which means all health commodities of these 3 districts to be transported by drone should be available at the district takeoff point colored in red. So it needs a good logistic coordination and organization. About these 5 takeoff points and district concerned, they are funded by various donors and they are chosen by the Ministry of Public Health for some criteria like the stockout history of health products, the inaccessibility, the insecurity, and also a radius of 100 kilometers from the district takeoff point and more criteria. Next slide, please. So how does it work? The drone takeoff point is installed near the district storage warehouse of the Ministry of Public Health to facilitate the transportation of medicines, the coordination and organization of flights. When products arrive at the district, the Ministry of Public Health sends to PSI Madagascar the public health facilities orders. After that, health commodities to be delivered are transported and prepared at the takeoff point by PSI Madagascar. And we inform also the public health facility head about the delivery planning. AerialMetric ensure the delivery of health product by drone. The delivery can be a routine or an emergency depending on the situation. The same for the number of flights needed to restock the public health facility. This project needs a very strong logistic coordination, as mentioned previously. Health commodities to be delivered should be available at the takeoff point. It seems to be easy, but not at all. Because if products are not available at the takeoff point, there will be no flights and public health facilities will not receive their needs on time. So health workers have to use the habitual system, which means working several hours or days to the district level in order to recover medicines. And to deal with it, we organize various coordination meetings with the Ministry of Public Health, led by the Ministry of Public Health, and the serious monitoring of supply chain from the central to the district. Next slide, please. About our work. So we are very proud because we have been able to deliver vaccines, malaria products, family planning, maternal and child health products from district to remote health facilities. And through all steps achieved, we can say that Jones works in Madagascar and makes health commodities available in remote communities, the whole EU. We count more than 3,500 delivery flights achieved and more than 180 of public health facilities and private restocking sites for community agents served. As the child health is also important, one of our mission on this project is to make available vaccines in remote area as well as other health commodities. And we hope having 2 other new seats soon under our donors fund. That's all about the global realization. Next slide, please. How about the government engagement on the project? In the beginning, the drone project was coordinated by PSI Madagascar. Then, the government engagement goes through the implication of the Ministry of Public Health on the project implementation, the coordination at each level, also on the creation and lead of the Technical Working Group Committee, which regroups representatives from various ministries like transport, public health, population, and also all technical and financial partners. The main mission of the working group is to provide technical advice on the planning, implementation, monitoring, evaluation, and review of the delivery of health products by drones to localities pre-selected by the Ministry of Public Health. And this working group aims to improve communication and collaboration among stakeholders, and which will lead to a more efficient use of resources with increased impact. In sum, the Ministry of Public Health is involved on all decision-making about the project, and lead also the project at the national, regional, and district level. Next slide, please. I think the next slide will be for Daniel. Thank you.
Thank you, Sandra. So, we've seen a project that's introduced since about 2019, that's been taken to a scale of over 3,500 flights. It's a project that received a midterm evaluation from our USA donor, which was more of a qualitative review of the evidence. And this study determined that that drones are effective at delivering health products. That basically means drones, you can use them, they can deliver them. It's appreciated by the community, it's appreciated by the various stakeholders. But the stage above that is trying to create the evidence that that drones actually have an impact on improving the health and lifestyles of the people and the communities that we're trying to serve, and that they can do this in a cost-effective way. So this is quite challenging. I think that there are a number of activities involved in generating evidence around drone use at the moment. I think what we have put together, and with funding from an innovation fund called the Fonds des Innovations de Développement, which is hosted by the Agence Française de Développement. What we're trying to do is to put together what we put together as a randomized control trial that's going a little bit further than looking just at the impact of using drones on the availability of commodities at the facility level. I think there are a number of other similar randomized trials that are working at the moment, but these are quite focused on supply availability. What we're trying to look at is to take the study a stage further to see if you increase supply, are you able to influence the quality of care? Are you able to improve job satisfaction among those among providers working in remote areas? And can you actually make a difference into the use and uptake of various services? Here we describe vaccination and contraceptive use, but there are other indicators that we'll be looking at as well. So if we move on, one slide. Yeah, so I've described this a little bit. We got a much longer theory of change, but if we were to just sort of try and summarize it fairly quickly in a way that's digestible, we're talking about here improving the availability of health commodities at remote facilities, which is reducing essentially stockouts. There's an assumption that this is a way of improving the quality of care, and this is the big assumption here is around the motivation of the provider. Are providers currently demotivated by the frequent stockouts that they have? And as a result, moving on to number 3, we see a lot of discussion about low uptake of services in the community, a lot of use of very low quality and informal providers as a common practice in remote areas. If people and the community increases, can have a higher confidence that when they visit a facility, there'll be more commodities available, there'll be a more motivated provider, that they will lead to increase in the overall use and uptake of services, and that will have an impact on the community. These are all aspects that we're going to be measuring through this evidence generation facility process. Please, next slide. This just, I think we've already seen a map of this from an earlier slide shown by Sandra. Just to give you a sort of sense of what we're doing here, we've got about 100 facilities, public facilities in this area. We've assigned half of them to an intervention group and about half of them to a control group. We'll be delivering supplies to the intervention treatment sites and not providing supplies, certainly for the first year, to the control arm. As Sandra said earlier, we're covering a range of different districts across different regions. She already described some of or she'll certainly describe later some of the challenges that we'll face around that, with just in terms of logistics and coordination. But please move on. Yep, so I think we'll describe the different levels of survey. So there's a household survey. It's just looking at the current state of health or use of facilities, the current status of contraceptive use, perhaps diarrheal diseases, these kind of things in the 2 weeks prior to the survey. We're looking at the different facilities that we have, the 100 facilities, and looking really at staff. Staff presence, staff when these facilities are shut, what levels of experience that the staff have. We're looking at their levels of motivation and absenteeism. We're also going into the community and looking at community health workers. So it's not just at the facility level, because the community health workers resupply at the health facility. So by improving supplies at facility level, we hope to also strengthen services in the community as well. And finally, we want to look at, we have using exit customer interviews, we'll be having a chance to look at client satisfaction and perceptions around quality of care. So moving on to the next branch, this really just shows the scale that we've done. Say just over 100 health facilities, that's with 170 health workers and over 200 community agents that have been interviewed, client exit interviews with over 500 clients, and over 1,000 household surveys. So I think this is quite a comprehensive study there. I think I've not really quite mentioned the our partners. I apologize for that. So we're working. This needs to be an independent activity. So the survey itself is being conducted in partnership with Innovations in Poverty Action. They are experts in randomized control trials, and the PI, the main researcher in charge of the project is comes from the University of North Carolina. Again, a very experienced research professional. We also have a health economist who is also based with the University of North Carolina, and he will be doing additional supplementary analysis looking at the cost effectiveness side. So this is the survey will generate the effectiveness, and we will be supplementing that with cost effectiveness information. I think one last slide just to show the time scale. Next slide, please. Yep. So where are we at now? We've just completed the baseline. We're waiting for the baseline study to come out. This will give us the basic situation in Madagascar, in the region we're trying to operate in, just the starting point around health. Our aim is to do 12 months of service delivery, 12 months of product delivery by drone, and then a follow-on survey from September, October next year. That will give us 12 months. Ideally, at that point, obviously, from an ethical point of view, we'll be aiming to be delivering as soon as the end-line survey is completed, to be providing commodities to all of the facilities involved in the study. Thank you. I think I'll stop there and hand back over to Sandra, who will give us some of the more generalized lessons learned. Thank you.
Yeah, thank you, Daniel. So these are some lessons learned, not all, but most important. So the first one, since the Ministry of Public Health is the lead of the project, the coordination is better, coordination of activities, and their staff at each level, national, regional, district, and also at the public health facility, are more engaged and involved on the project. So PSI continue to support the Ministry of Public Health on this way. Secondly, having also the support of the local authority is very important. Why? Because they facilitate the implementation of the project, the execution of activities, for example, sensitization, information of population, and we have been involved, the police also, about launch of activities. What else? For the community engagement, the community is also engaged on all activities like jobs on identification, securization during the delivery, and more. About the communication. The communication is very important, because one wrong information and products are delivered at the wrong destination. That's why we continue to improve the communication between all actors. And the last, for each scale-up, some criteria must be considered before the selection of a new take-off point, a new site. Example, for geographical weather condition, it should be appropriate also for the drone specification, and each takeoff point has its own criteria. Next slide, please. So this slide will end the intervention of PSI. This is the PSI team who work under this project in Madagascar. So I give the floor to Pierre-Lou for the next. Thanks.
Thank you, Sandra. I think we have a few minutes left, so I can give you a very quick overview of what we do at AerialMetric and who we are. So this is a picture of our drone actually flying in Madagascar with our motto, taking care by air. So this is really what defines us in the sense that what we do is we use drone technology to come and help vulnerable or isolated population in Africa. And that's not only through the delivery of health products, but they're also, as we will see very soon, other types of services that we can provide by drone. So if you can, next slide. So on this slide, I present the three different silos of services that we currently offer. Actually, AerialMetric was born more than 10 years ago in Madagascar, way before I joined them. And it started with mapping and surveying services by drone or by plane. That's how AerialMetric was born. And then, as both Daniel and Sandra said, in 2019, it moved to healthcare delivery and developed their own first cargo prototype to provide with this kind of services. And that's the drone you've seen on the pictures. And more recently, in 2021, we started to conduct spraying activities by drone using another type of drone. And that was an activity that was part of the fight against malaria in Madagascar. I will come back to that. Next slide. So this is the matrix of the services and verticals we currently cover. So the green tick is what we currently do, and the orange one are what we are about to start or what we are prospecting into. So obviously we are still active in the whole health vertical, whether it's cargo, spraying insecticide to kill mosquito larvae, or mapping before any health project. Usually there is a preliminary mapping phase. So on this vertical, we are very present, and we continue to be active. We are looking, of course, at expanding outside of Madagascar in this vertical. I'll move to the agri and forestry because this is something that we are just about to secure with the private sector of Madagascar, and we should be early 2024 starting to do some spraying activities using our T30 DJI T30 drones to fight some kind of what do you call that, caterpillar that affects maize crops in the north of Madagascar. So that's a new area for us, and of course it's directly related to the experience that we have in the spraying, but for health against malaria. And conservation, we've conducted already several mapping projects for forestry to monitor the state of forest in Madagascar. But there are also potential activities in seeding and reforestry, and we're looking at that as well at the moment. Next slide. So on this slide, I just try to show how important it is to AerialMetric to measure and look at the impact we have, whether it's health or environment or economic related. We are above and beyond all an impact company. So for us, it's important to change somehow the lives of the people we serve. So as I said, obviously we impact on, as Sandra and Daniel said, we impact on the health of people that receive our vaccines or medicines. But we also naturally and positively impact the economy of Madagascar. Now we have a team of almost 80 people, almost all in Madagascar. So obviously we created some job. I think we are the #1 hire of pilots in Madagascar, even before the national company in Madagascar. And we work, as we said, also on preserving nature and helping NGOs working in this field. Yeah. So I think these numbers have been already given, and these numbers are only the PSI Madagascar numbers. We've also flown with the UNFPA, so we have a few more flights under the belt with them. We've flown for a year with UNFPA in the south of Madagascar, and I think we covered about 60 CSBs there, public health facilities. In the South of Madagascar for UNFPA. Unfortunately, this project didn't continue. So these are the numbers for PSI. So yeah, importantly, what's important about us is that we are a hybrid private company. We both design, manufacture our own drone, and also in some instances use other companies' drones, such as the DJI T30 or other mapping drones. But what takes most of our effort is really the designing and the manufacturing of the cargo drone you see behind this picture, on this picture. So we have a facility in Tana that employs almost 80 employees, technicians, pilots, and engineers. Almost all of them are Malagasy, and close to 30% are women, which is remarkable in the technological field. Just a few technical specifications of the drone we currently use for healthcare delivery. So it's a VTOL type of drone, meaning that we vertically take off and land. So we only use the VTOL aspect at the takeoff. We currently don't land at destination. I mean, this is something that has often been required from us, but because it's still quite risky to land really far from the top, from the takeoff point, we don't do it yet. Although it's in the pipe and should be coming early 2024. We don't do two-way delivery because of that. We parachute the goods at destination. The drone is actually quite fast in its category. The cruising speed is about 100 km per hour with a max speed of 150. Usually flies between 2 and 2.5 hours at most. It's a large drone with a wingspan of more than 3 meters and a maximum takeoff weight of 32 kilos, which puts it in the heavy category of similar drones. The max range is 225K. That's a distance we've actually flown, but for safety reasons, we usually limit this range to 200K, meaning that when we take off from a given base, we can serve or deliver a health facility at up to 100K from the base. We fly with quite strong winds, up to 15 meters per second. The rain is not an issue. On average, I think the payload is about 3 kilos, but we could carry more, especially if the range is short. Obviously, for the vaccines, we have the capacity to offer, to respect the cold chain and maintain temperatures within the payload between 2 and 8 Celsius. And as I said, so we are actively developing the two-way delivery with the landing at destination. It's been more and more required, not just in Madagascar, but in other countries. So that's something we are looking at. Regarding fail-safe and safety, so our drone is one of the very rare drones in this category to be equipped with triple telemetry, so radio, 3G, 4G, 5G, and SATCOM, meaning that we never lose contact with the drone. And there is also a safety parachute on the drone in case of any issue or whatever. The drone will be slowed down if need be. On the spraying, I will wrap up quickly because I see that time is counted. We've conducted two campaigns in 2021 and 22 for another NGO, American NGO called Apt Associates. And we've been spraying over 25,000 hectares in the central part of Madagascar and south of Madagascar, killing larvae of mosquitoes using a bio larvicide. So that has been a success, real success. We've protected hundreds of villages against malaria using this larvicide. And finally, so these are our current client or past clients, or donors, I should say, not just direct clients. And I think this is it. Thank you.
Thank you, thank you. Very exciting. Great job, Daniel, Sandra, and Pierre-Loup. Amazing accomplishment. A reminder to everyone what PSI with AerialMetric are doing is beyond the proof of concept. It's beyond short-term project. This has been going on for they've been flying for a few years. So as Daniel mentioned, it's really one of the few who has successfully reached the point of ongoing operation for a long period of time at a certain level of scale, which is really impressive as demonstrated. So now let's get to Q&A. So for everyone, if you have a question you want to verbalize, please raise your hand, and then unmute, and we'll let you unmute yourself to ask your question. Maybe I can just start. Can you guys speak a bit about how the integration of this additional mode of transportation has been operationalized with the current public health supply chain processes? For example, how do you or the Ministry of Health staffs, the healthcare workers, or the district manager decide what product goes where, which facility goes where, and how do you track what product is going where and when and so on? So the whole data management. So it would be great if you could talk about what I call the integration of this additional mode of transportation within the public health supply chain processes.
Yeah, thank you for this question, Olivier. I think I can answer this question. So, as I explained in the beginning, public health facilities are selected by the Ministry of Public Health with some criteria. Then we evaluate the quantity of product that they need the whole year, for example, and we plan flights depending on these needs of public health facility. And we collaborate very closely with the head of the district of the Ministry of Public Health. They give us what quantity of product and what kind and quantity of product and which health facility we should served during this month. So the The delivery may be per month or per quarter, depending on the CSB needs. And the Ministry of Public Health is very engaged on this project and very involved. About data, we developed an application, and this application is used for flight planning, also about orders from the public health facilities, and all data about the flights delivery are on this application. I don't know if is it okay, Olivier?
And perhaps to add to what Sandra was saying, just to put add a bit of context there. So the national supply chain system is essentially managed by Salama, which is the the centrale d'achat in French, equivalent to medical stores department in maybe some Anglophone countries. Their responsibility is to deliver down to the district level. There are about 113 districts in Madagascar. What the drones are doing is basically connecting the district to the health facility. So that's the sense that it's fully a complement to the national supply chain system. As I'm sure we'll get some other questions. A lot of the most of the commodities, the routine commodities perhaps are delivered through the people from the health facility coming on either twice a month, maybe every 2 months or possibly every 3 months, traveling to the district level to pick up commodities. That means that on the day they arrive, if the commodities are not available, if there's been a stock out of that particular commodity, they would go back empty-handed to their facility. And I think that's where a lot of there's an element of gap filling that the drone is able to do. If the week afterwards the commodity has arrived from the center to the district level, that's when that you can miss out. If there was no drone there, the facility may have an absence of that particular stock for maybe 2 months, maybe 3 months. And so that's where you can ensure that that you can get a better continuity of supply. When our capacity is not yet one where we can deliver routinely all of the commodities that might be wanted. But yeah, I'm hoping that's answered some of the questions there. Thank you.
Thank you, Sandra, and thank you, Daniel. There is a few questions on the Q&A from Matthew Gaffney. Be interested in hearing more about the regulatory work you had to perform for approval and any challenges and mitigation that you took.
Okay, I think this is a question for me. So things have evolved a lot on this front in Madagascar when AerialMetric started to fly back in 2019. I mean, the regulatory context was pretty flexible, I should say. Now the local civil aviation is just about to publish and put in action a new regulatory framework for drones at the end of this year. And that has forced us to have several manuals that were not yet ready, both for the drone itself, but as well for the company to become certified. So we are in the process of becoming an ATO and be recognized as a drone operator by the local civil aviation. So yeah, the regulatory context is becoming more and more stringent, and we are adapting. We've had no choice other than to adapt to the request from the local civil aviation. So yeah, this is a heavy effort for us to develop all these materials for both the drone and the company, and be aligned with their requirements.
So maybe a compliment, Daniel. I'm guessing you guys are really close to the civil aviation authorities, and you work hands in hands and often with them. both to help you adapt, but also to help them develop their regulatory environment, so providing input on the regulatory and trying to contextualize it. Is that, well, that's what Village Reach do where we work, but I'm guessing, is that the same thing in Madagascar? Daniel,
Oh, sorry. Are we influencing the regulations? I think, Pierre-Loup, I'm sure his team are working closely, doing their best to sort of engage and sort of share information. We, I think our influence has perhaps been less at the regulatory level, but more at the national policy level, working with the Ministry of Health and forming the national working group, as Sandra described above, and bringing together the different partners into that, into a talking shop. So, that we are not the only people working on drones, as Pierre-Loup said. There's UNFPA and there's also Abt Associates have historically, and there are a few other people coming in. So, it's a chance for the different stakeholders to get together and discuss some of the challenges and actions going forward.
Great, thank you, Danielle. And maybe when Pierre-Loup comes back, there is a couple more questions on the regulatory that I'm going to pass. A question from Pedro. Do you have any concurrent telemedicine project that generates synergies with your US cargo project? Probably for the PSI team.
Yeah, I can take that. The answer is fairly no. I think the ministry has been discussing options around telemedicine. They're very cautious. There hasn't been a big step forward in that area. I guess in theory you could have a telemedicine system and then an individualized, personalized delivery of a health product around that. We're a long way from doing that at the moment. We're just really talking about stocking the basic health facilities. I think that a personalized delivery of the sort being described there would, at this stage, still be too expensive per person treated, per product delivered. Given that most of the commodities we're talking about are in some ways fairly straightforward, fairly basic. Obviously, a vaccine is life-saving, and many of them are life savings. But we're not talking sort of high end, we're not talking about blood delivery or things like that would ideally, those sort of things could be sort of very time driven, life-saving activities. Thank you.
I think another question for you, Pierre-Loup, and I'm going to combine them. First of all, can you confirm that your flights are autonomous, and that you do not have an individual pilot like teleoperating the drone? So that's one question that I have there. And the second is, are you, when operating drone, can you utilize the specific operation risk assessment methodology, the JARIS, used in Europe? And does the civil aviation accept this accept this? This is a question from our friend and colleague, David Guerin.
Okay. On your first question, David, well, we have usually two pilots, two teleoperators per drone. So they don't pilot per se the drone. Of course, the whole trajectory or route is programmed, and the drone flies by itself. However, we need the pilots at takeoff and landing in case there is wind, or in case the drone needs to be piloted by hand. So we always have pilots on site. So that's one. On the SORA and risk assessment aspect, so we've conducted SORA for the civil aviation of Madagascar. However, it's not yet mandatory. As I said earlier, I mean, the regulatory context is still pretty flexible, and this is one of the chances we have being in Madagascar, to have this capability to fly a lot compared with other countries in Europe or other continents. So these are the things that are going to be demanded more and more. But until now, we didn't have to conduct the same type of assessment as we would have done in Europe, for example.
Thank you. Next question. We have 5 minutes, so let's try to be short in the answer. Question from Tushar. What is the overhead of employing VTOL drones in terms of its operations? First question. And what is the durability during hazard like floods? Are they being used in disaster risk management perspective? A couple questions within one here from Tushar.
So I'll touch on the second question on the emergency response. I mean, it's always difficult to be ready when there is a disaster. Obviously, I mean, we should, I mean, for AerialMetric or PSI to be able to react quickly when there is a cyclone or flooding somewhere in Madagascar, that would mean that bases with operational drones are already more or less everywhere. And this is far from being the case because of the size of the country. So until now, this is not something we have really done. We are more into the routine type of operations than the response to emergency situations. But yeah, it could be, I mean, it should be, I should say, even say it should be one of the things that drone could cover, especially Madagascar, which is hit every year almost by cyclones or flooding. Yeah, it's a question of preparedness. Yeah.
So the other question is about the overhead of employment drone in terms of its operations.
So I'll let Daniel respond to that and maybe complete.
If we want to talk about if the total cost of drone implementation, I think we're not. I'm not going to talk about the specifics, perhaps, but we're working on a drone delivery as a service model. So we're working on a monthly fee. It's there are significant costs involved. What we're trying to demonstrate with our randomized control trial approach is that the outcomes are things that are worth investing in. That you can, and the cost effectiveness per outcome is something that donors will be willing to invest in the future. Drone technology is likely to come down in cost over time, and so we think that at the moment, if we can demonstrate that it's something that can make a difference at the last mile, which is always something being discussed in Madagascar as being the challenge that we haven't yet overcome. If we can find that solution, there are lots of potential, lots of possibilities for the future. That's not a short and direct answer, but we're hoping to get answers to that over time. Thank you.
Yeah, and maybe I can add to this. We cannot really compare the cost, the cost of operation from one sitting to another, and we see that we experience that Village Reach clearly. Very different costs between Mozambique and Malawi and the DR Congo. So 3 countries, they're all very different, especially between Congo and the 2 other countries. You can't compare from one operation to another. It's just too much contextualization of the price. Gabo, I think you have a questions.
Yeah, just sort of tangential to that question for the PSI team. What is the scope of the costing exercise of the one portion of the costing of the cost effectiveness? What exactly are you costing and what are you comparing it to?
I think one of the areas that we're planning to do is to sort of either we'll do this conceptually, though some of our partners are doing some of the practical work around this, comparing to, so let's say, motorbike delivery of equivalent products. you know, people often say, why do we need to be go through such high technology when, you know, you could find much simpler solutions? It's interesting when we do talk to Salama and some of the other providers who are exploring some of those ideas themselves, they just come back and say how expensive that is. And you know, when you're doing a surface level transport, what you're ending up with is a situation where you're always going to serve the nearest points to the start point. Any sort of introduction of a new technology like a motorbike doing surface transport is going to serve the nearest points, the nearer points much more efficiently than the further points. I think it's almost only the drone technology which can fly over and within an extra 30 minutes can serve something 100 kilometers away, versus a surface transport that would take an extra day or 2 days of per diem, motorbike repairs, etc. That's what we would like to try and get into as a comparison. What else are we going to look at? It's more about outcomes divided by current cost, and then with a health economist, perhaps look at how our ordering and how our planning could be improved. There's the smaller operational aspects. In view of the time, I think I'll probably stop there.
Yeah. Exactly. Thank you so much. We have a few more questions that maybe we can respond via email to the members. Thank you so much, Sarah, Daniel, and Pierre-Loup. Thank you so much for your question, everyone. And we will be posting this recording on the website, the Updwg website, before the end of the week, and we'll send it to the registered and members. That's it. Thank you very much, guys, and have a good rest of your day.
Thank you.
Thank you very much.
Thank you very much.
Bye.
Bye-bye.